So I'm going to actually go through two of those three ideas, the mitigation and resilience ideas, really beginning with how do you mitigate your climate change impacts. And it sort of centers around this idea of reducing energy and water use. And I'm going to talk really about, again, going back to the Lancet Commission report, that there are some hospitals who can really frame this as greenhouse gas reduction and set visible GHG reduction targets in their communities. Hospitals in the Northeast, hospitals in some regions of the country. Other regions of the country actually are finding, because of the entire politicization of climate change, it's best if they frame reduction of greenhouse gases as a health issue. And so you also see hospitals around the country framing around actually the particulates in fossil fuel emissions and reducing fossil fuels as a public health improvement. And the first health system I want to talk about is in Wisconsin, which operates, of course, on a coal-fired grid and is a place where climate change conversation is not easy to have. So is anyone here from Wisconsin? Yes. So Gunderson, when they set the goal to be energy independent by 2014, they set that goal in 2007. They defined that as producing more renewable energy than they consumed. And they framed it around this, making the air better for patients to breathe, controlling their cost, and helping their local economy. It was not about climate change. They never talk about climate change. But what they did is actually a whole series of renewable energy partnerships with their community. And these are fairly powerful partnerships. They put the entire town of Cashton, Wisconsin on wind, for example, a town of 2,500, now completely wind. They tried to harvest methane from City Brewery, which is next to their La Crosse, Wisconsin campus. The methane really didn't kind of work so well. It wasn't clean enough, and the brewery actually went out of the beer business and moved to hard cider, and it doesn't quite have the same chemical profile. But one of the things they realized is the day they made the announcement that they were going to harvest methane from the local brewery, their phone was ringing off the hook with other ideas about harvesting methane. Methane from local landfills, methane from cow manure. And so actually the brewery partnership didn't work very well, but it unleashed a whole lot of potential in the region that actually has worked for them to become energy independent. If we go to Greensburg, Kansas, it's a completely different story. Greensburg was destroyed by an EF5 tornado in 2008. That's a town of, again, about 2,000 people. This is a federal critical access hospital that was completely destroyed in Greensburg, Kansas. When the town rebuilt, they built the second LEED Platinum hospital in the country that runs completely on wind, the first 100% renewable energy hospital. And actually, there's even a cooler story here that the wind turbines for Greensburg, the entire town is on wind, and the hospital has its own wind turbine for its base electrical load. But these wind turbines actually were all produced by John Deere. And this was John Deere's entry into the renewable energy market. They kind of looked at these wind turbines and went, we could build those. They ultimately went into the wind business, and then when the market collapsed, they sold it. So they're no longer in the wind business, but it does kind of show the power of ingenuity. The hospital was initially excluded from having to do 100% renewable energy, but they said, well, why not? If the rest of the town can do it, we can do it. And then moving actually to Nepal, the purpose of this slide is to say that we've tended to believe that the developed world has not much to learn from the developing world about technologies and healthcare, but I'll tell you that in the world of renewable energy, that isn't the case. The world is much flatter. And when you go to parts of the world that do not have reliable infrastructure, that have no electrical grid, et cetera, and you watch nonprofits building hospitals to do heart surgery for Doctors Without Borders, and these are fully air-conditioned, solar-powered hospitals, you say, I see, it can be done. So I think there is sort of two-way learning that we have to kind of get to. The second thing is to really adapt, and that means to improve our infrastructure resilience. Tom Fisher, who's the dean at the Architecture School at the University of Minnesota, wrote this book called Designing to Avoid Disaster. And the cover is actually the Minneapolis bridge that collapsed not that long ago. This is actually his sentence, that centralized infrastructure from power grids to hospitals are larger and more complex. He calls them fracture critical, that they've gotten so complicated that it only takes one thing to bring them down, and they have no inherent resilience. And he says we really have to kind of think about the understanding that nothing's going to work as planned or even at all. And we're really at our best when we've imagined for the worst. And this is what hospitals are supposed to do. They are high reliability organizations. They're always planning for the worst, except when it's come to their infrastructure resilience. So when you think about the Texas Medical Center, 2001, Tropical Storm Allison, this actually was a storm in which 30 inches of rain fell on Houston in 48 hours. It completely flooded the largest medical center in the world, did billions of dollars worth of damage. There were actually submarine doors in the hospital, but they'd been installed 30 years ago. No one remembered how to use them. Or, the University of Texas Medical Branch, Galveston Island, Hurricane Ike. One of the nice things about hurricanes is they generally give you enough warning to evacuate, so they did manage to evacuate the entire UTMB campus before Ike hit. But it took them about 6 months to get back at all after the storm, and again, billions of dollars worth of damage. So what happens? What goes wrong? First of all, this severe weather, all these buildings are designed to threshold conditions. Maximum wind, maximum rainfall in 24 hours. That's what architects design to. That's what building codes recognize, threshold conditions. Threshold conditions no longer apply with climate change. They're all different. So how are we responding to that? The duration is another issue, that we often think that this weather is going to come and then go, but we're finding that the durations last longer, like the extreme rain that goes on for 48 hours instead of 4 hours. So duration is a problem. Then the geography is changing, given extreme weather. So areas of the country that haven't had these extreme events are now experiencing extreme events. And last but not least, all the municipal utilities are getting older. And so when this extreme weather takes down utilities, it takes them longer to come back. We have an emergency power system in hospitals that's predicated on the idea that the squirrel chews through the wire, and maybe you're going to lose your power for 3 or 4 hours, and then the utility will send a crew out there and they'll fix it, and everything will come back. That's what diesel generators are for. They are not really designed to run for 7 days in lower Manhattan when the utility doesn't come back. So how do we deal with that? How do we deal with the fact that our need for reliability has outstripped our utility's ability to guarantee that reliability? So after Sandy, this is what New York City said. This is what we have to do. We have to reduce the risk of evacuation. We have to be able to take on the acute emergent patient needs, all the surge that happens in an event. We have to avoid extended outages, and we have to reduce how many people can't get to their normal doctor. And so that means we have to operate continuously or we have to reopen quickly, neither of which happened to Bellevue or NYU Langone post-Sandy. I'm from New York. So this is basically how you summarize that. We want our healthcare systems to function well under stress. We want them to successfully adapt, to be self-reliant, and to have inherent social capacity. That's what we have to get to. So if we look at Texas Medical Center today, after Allison, they actually participated in a whole community program for the Bray Bayou, right, marsh. So now upstream, there's all this flood control. They pulled the river out of concrete banks with the Army Corps of Engineers. They made these marshes to better absorb water. The medical center itself ripped up its surface parking lots. It worried about groundwater infiltration. It gave the campus a place for water to go. In the floods in Houston this year, the Texas Medical Center did fine. They also, of course, moved their infrastructure up. If we look at Charity Hospital in the VA in New Orleans, this is a hospital built upside down. The emergency department is now on the second floor. You ramp up to get to it. The ramp is a boat ramp when there's a flood. What's interesting about the rebuilding of hospitals in New Orleans is that they're all rebuilt as if the levees will fail, going back to that Tom Fisher comment. They are not relying on municipal flood control to work. And how many of us live in communities or practice in communities where we don't even know what the threshold conditions would be if there wasn't flood control upstream, if the dam failed, if there was a catastrophic infrastructure failure? UTMB took everything that it had low and built a whole clinical services building. So it put its laundry, all the stuff we usually have in basements, laundry, imaging, et cetera, moved it into a freestanding building. And I want to sort of say that a lot of these ideas, actually, there's a kind of set of resilience ideas like backup generators, how you elevate things, flood barriers, all that sort of stuff. Then there's a whole group of strategies that really cross over between sustainability and resilience. So what I talked about initially, the mitigation, if your hospital uses less energy and less water, it means it runs longer on any fixed supply. So there's a whole set of strategies that kind of do both things. The natural ventilation that Gary alluded to with people throwing furniture through. And then there's things that are pure sustainability features that we're not really going to focus on here today. But there's a really rich place at the intersection of sustainability and resilience. And, that's what ultimately Kiowa realized, that they realized that this tornado really caused them to shift their decision-making and realize that investing in long-term energy savings and sustainable and renewable resources had to replace their lowest capital cost thinking. And I think that's the lesson from around the country. I'm just going to briefly mention Spaulding Rehabilitation Hospital in Boston. This is the first building on the Boston waterfront of any type to be specifically constructed with sea level rise in mind. It's gotten more press for that feature alone than anything else about it. It's built upside down. All its infrastructure is at the roof. It's elevated. And this is a key feature of it. It has operable windows that are keyed open in an event of systems failure, and that was specifically in response to what happened at Charity Hospital after Katrina. They said wouldn't happen to us. First, the building won't overheat that badly because it's a really well-insulated and shaded building, but secondly, has key-operated windows. So it's thinking about what we can learn from these disasters. And this will be my final comment, is that in other developed places in the world, hospitals still rely a lot on natural ventilation. So in the UK, for example, many of the post-World War II hospital buildings in the National Health Service use natural ventilation principles. They're not sealed and fully air conditioned. They've been looking at temperature rise in England and trying to figure out whether they will have to seal and air condition their buildings after having operated them for 50 years with a relatively low carbon footprint while they've committed to 80% carbon reduction. So they did a whole study with the University of Cambridge about whether there were ways to retrofit their buildings to be able to continue to comfortably operate using natural ventilation in the face of more extreme temperatures. And the answer came back, yes, there was. So these are the kinds of calculus now that are happening around the world as people wrestle with how do you reduce your carbon footprint, keep your resilience, and keep thermal comfort and asepsis conditions for patients to receive care.